Logan has put in a lot of work over the last year and a half to establish a naloxone distribution program at UHB in the ER. And this is going to enable us to hand out naloxone kits to patients who are at risk of overdose. And that includes not just people who are abusing opioids as drugs of abuse, but people who are on high-dose opioids for chronic pain, a lot of our sickle cell population. So even though Brooklyn is actually kind of on the lower end of the opioid overdose spectrum compared to other parts of New York, like Staten Island and the Bronx, we still do have a lot of patients that are at risk, and it's going to be an important thing. So I went to the training at the Harm Reduction Coalition with Phil Matthews, who's a PA who does a lot of this stuff, and he's not really doing as much training in the ER. He's doing it in places where these patients are easier to find, on street corners, things like that. So he's got a lot of experience with this, and he did a really great presentation. I'm going to do a much shorter version because it was a 3-hour thing. I'm kind of cutting it down to the essentials of what you need to be able to tell the patient in order to distribute these kits. I also sent the handout that you can use as a cheat sheet for the first few times that you do it. And the parts that are in red are really the most important parts that you really need to get across to the patient. So in terms of the training, the essentials, these are the things, you got to get these points across if you're going to give a kit to somebody. What does naloxone do? How to recognize an overdose, how to do a sternal rub, what you do next, administer naloxone and call EMS, putting someone in a recovery position and getting them to report and get a refill when they use a kit. If you have enough time, if you're working a Saturday and you've got a lot of patients that might be at risk and you have some time to talk to them more, you can go through the risk factors that people are at risk for overdose, including people who lose their tolerance, people who are using by themselves and mixing drugs, and then elements of resuscitation and rescue breathing is probably going to be the most important of those. And then the Good Samaritan law, the potential protections for people who might be afraid about involving authorities at the scene of an overdose. One of the most important things to get across for a layperson perspective is that giving naloxone to somebody who doesn't have an opioid present is not going to cause harm. People are worried that they're going to hurt someone if they give a medicine and they're not an expert. And this is something that you really need to get across to them. They shouldn't delay action because they're not sure. And even though we, with a little bit more sophisticated understanding, know that potentially somebody who's on methadone maintenance and overdoses on Xanax today, potentially you could put them into withdrawal while they're still sedated and they potentially can hurt them. In most cases, it's going to wind up being beneficial, and it's better for them to act than not to act. And somebody like that may actually just wake up, and even if it's not the primary thing that they overdosed on today. So don't feel bad about telling them something that you may have a little bit more sophisticated understanding of. The most important message to get across to these patients is naloxone is safe and effective. You can't hurt someone by giving them naloxone as a layperson. You should explain that it causes withdrawal, and that it usually works in 2 to 8 minutes. It works basically pretty quickly, and it lasts for 30 to 90 minutes. And that basically it's safe, well-studied, and it's not something that you can abuse. You don't need to go through this whole list, but just make sure that people know that heroin is an opioid and that prescription pain medications are typically opioids, and those are the things that we're going to consider naloxone for. They should understand that it doesn't work for alcohol, benzos, stimulants, but even if you give it to the wrong patient, you're not going to hurt them. How do you recognize an overdose? The most important thing for the layperson is somebody's unresponsive and you can't wake them up. For us, we think about giving naloxone to people who are hypoventilating, but for them, the most important thing is the patient's unresponsive, you can't wake them up. If it seems like they're not breathing well, they're having noisy breathing, turning blue around the nail beds and the lips, are other things that you should bring up. But the most important thing, unresponsive, can't wake them up. That's when you give naloxone. When you find someone who's unresponsive, wake, shake, and shout, "Hey, you okay?" Loud, right? And then sternal rub. And so you'll try to demonstrate that you're going to use your knuckles on the breastbone. And even if that doesn't wake a person up, it might take someone who's not breathing or not breathing adequately and make them breathe. So in case of an overdose, the two things that they need to know to do is call 911 and say, my friend is overdosing and not breathing, and give naloxone. It doesn't matter which you do first, but you have to do both. So if the naloxone's in your car, call first, then go get the naloxone and give it to the patient. If you have the naloxone handy and your phone's in the other room, give the naloxone first, and then go call EMS. So do whichever is easiest to do first, but do both. We have to explain how to do it, and it's basically, for us, we're going to have the nasal kits. So the Narcan is the brand that we have. It acts within 1 to 8 minutes. If they don't get a response within 2 minutes, they give a second one. So there's two doses in each kit. So no response with the first kit, they give a second dose, and they should know that it lasts 30 to 90 minutes. So you can demonstrate with this. It's really important that they know that they shouldn't open it until they're about to use it, and that they have to be careful not to discharge the medicine until it's in the patient's nose. So they're going to peel off the back of the thing, stick the nozzle into the patient's nose until their fingers are touching the nose, and then squeeze. And if they wind up needing to use another kit because the patient doesn't have a response in 2 minutes, then you're going to use the other nostril. It's important that they understand the recovery position, so if they have to leave the patient's side, maybe to go get the naloxone or for whatever other reason, they should put them on their side so that they don't do a jump Lucy and puke into their airway. So if you do give it and the patients wake up, you have to explain to them what happened. They may be confused, explain that you reversed the opioid that they took, and that you did that by giving them naloxone. You want to reassure them that it's going to wear off in 30 to 90 minutes and discourage them from using more drug to try to escape the withdrawal, because that puts them at higher risk for opioid overdose. And you want to encourage them to get medical attention. So at this point, there's kind of two situations, because a lot of our trainers, a lot of our patients that we're going to be training are not going to want to call EMS when they use the kit. And so at this point, if they haven't called EMS and they've given the dose and reversed the opioid, there's kind of two situations they might encounter. The patient's not okay, they got to call 911. If the patient's okay, they got to stay with the patient for 3 hours. Right? So if they don't call 911, you can't leave the patient's side for 3 hours. You got to watch them. You can't go to sleep either. So two situations, and just remember to just put it to the patient that way. Patient's okay, wait 3 hours. Patient's not okay, call 911. Anytime they use a kit, it's important that they report it to the program. The form for doing that is in the kit. It really helps to have data on this, and it helps support these programs. Right now, most of the data that is out there on naloxone reversal in the community is from police, because they fill out the forms every time they give a kit. And so every single one of these, if they can give it, it's very valuable. And they should be proud about having used the kit. They saved someone's life, and maybe try to put it to them that way to try to encourage them to fill out the form. Whether they fill out the form or not, they need to get a new kit when they use it. Even if they only used one dose in the kit, they want to have two in case the next time they need both. So in terms of the option, so those are the required elements. So if you get through all those things, you can give someone a kit, and the kit has a card in it, and there's a log that you'll just have to fill out that you gave this person a kit and did a training. If you have time, you can cover, and if the patient is willing, you can cover these other things. So risk factors and resuscitation and Good Samaritan law. So in terms of risk factors, one of the most important risk factors is reduced tolerance, and we'll talk about that in a second. Second is using alone, and third is mixing drugs, and then there's a number of other elements that often it won't be things that you have as much control over. So in terms of tolerance, most of these patients will have a basic idea of tolerance, but basically the idea that increasing the dose has less effect over time. And when patients are in a situation where they lose tolerance, like incarceration or hospitalization, or they're in a detox program, it doesn't take that long for them to start to lose that tolerance. Within 3 days, their tolerance is going down. So if they go back to using the dose that they were using before, it's a really easy time for them to overdose. And sir, this is a diagram looking at causes of death in people who were released from prison by a week after they were released in prison. And the darker color is overdose deaths, and the lighter color is non-overdose deaths. And you look in the first week or two after release from prison, you see so many overdose deaths, and it's because of that lost tolerance. Other risk factor is mixing drugs, especially mixing with other depressants like benzos or alcohol, or mixing multiple different opioids. But even mixing with a stimulant like cocaine or methamphetamine also increases the risk of overdose. There's less data on other sedative medications like antidepressants and antipsychotics. So data from now 2 years ago, in New York City of overdose deaths involving multiple drugs, almost all overdose deaths, 97% involved more than one drug, and alcohol was a really common one. So opioids were the most commonly used drug in overdose, 82%. It included heroin, fentanyl, methadone, and prescription pain relievers. But cocaine was present a lot of the time, almost half. Alcohol, 40%, and benzos a third of the time. So mixing drugs is dangerous for these patients, and it's another thing to think about when you're prescribing. This isn't really part of the training, but in terms of prescribing both benzos and opioids at the same time to a patient. So for resuscitation, if they don't seem like they're breathing, if they're trained in CPR, then they can start CPR, rescue breathing and chest compressions. They can do rescue breathing alone or chest compressions alone. Even though there's some data that chest compressions alone may be adequate, for opioid overdose, really the main problem is that they're not breathing, and you want to address that. So if you're going to only do one rescue breathing, it's probably the thing that you want to do. And there is a rescue breather in the kit, so you can use that. Teach the chin lift, head tilt method, and close the nose, 2 breaths, look for chest rise, clear the airway if you don't see it, and then repeat. 1 breath every 5 seconds. We all know this from BLS. If you have time to teach this, it's great. I think it's less realistic that we're going to be doing this in the ER. This is part of the optional part of the program, but it is, is something if you have time that you can talk to them about. One thing that people probably will want to know about is the Good Samaritan law, and that protects people from who use these kits from being prosecuted. They basically can't be prosecuted for possession of drugs up to an A2 felony offense, which means up to 8 ounces of narcotics. They can't be prosecuted for alcohol if they're underage. They can't be prosecuted for marijuana or paraphernalia or sharing of drugs, which in New York State actually counts as selling. So all of those things they don't have to worry about by involving the authorities when they use a kit. There are some limitations though. So it only protects the person who overdosed and the person who called 911. It doesn't protect anyone else who's around. And it doesn't protect if there's an open warrant for your arrest, or you're on parole, or if you have a conviction for A1, A2, or B felony possession. So that's like a half a pound of marijuana. It's a fairly large amount. If somebody maybe has a history where they were convicted of one of those things, then they're not really protected by the Good Samaritan law, and they should know that. And if there's other crimes on the scene. And New York is one of the many states that has Good Samaritan laws that offer these protections. I think we can mostly skip this. We're all pretty familiar with the fentanyl and fentanyl derivative epidemic. It's become a really big problem. We see a lot of it in Staten Island and the Bronx. And I'm sure that it's happening here. We just don't see it as much. I think we all know everything on here. I think everyone's aware that fake pills that may not even be for opioids contain fentanyl. Sometimes there's fentanyl that are counterfeit Xanax that are out on the street. So you may get somebody who isn't even opioid tolerant at all and isn't looking for an opioid, who gets an opioid because they're getting these counterfeit Xanax and winds up overdosing. It's present a lot in cocaine overdoses as well, and it's not just speedballs. There's actually fentanyl adulteration in cocaine at times. In Ohio, from January, February, just a year ago, 90% of unintentional overdose deaths were involved fentanyl. Heroin was only found 6% of the time. So a lot, in some places, fentanyl is completely taking over what used to be the heroin market. And an interesting thing, and this differs a lot from heroin, in heroin overdoses, they typically take place over 1 to 3 hours it takes to die of heroin overdose. It's not typically as quick as like what you may have seen in Breaking Bad. And so people kind of will have varying respiration over a period of time before they finally have apnea. But fentanyl overdoses seem like they happen much quicker. In one study, they found that 32% of the people who had fentanyl in their system when they died didn't have any norfentanyl metabolite, which means it happened before they could actually metabolize any of the drug, so pretty quick. So in terms of harm reduction responses to fentanyl, naloxone is a really important one because most overdoses happen with a witness, and having someone on the scene is really important. People can use a tester shot or a slow shot. I'll tell you what those are in a moment. There are fentanyl test strips are available if people are using in a group to take turns so that not everybody is going to potentially go out at the same time if it's more potent than they expected. Not using by yourself. Don't be afraid of calling 911 when a patient's in trouble. And these last two I don't really think are responses to fentanyl specifically, but more to opioids in general. What a tester shot is somebody uses a smaller dose than they would normally use before they use the full dose. It leads to multiple punctures, and people are less likely to want to do this. The slow shot is basically kind of what we do with diltiazem. When we give a dose of bolus diltiazem, give it slowly and look for effect, and so you're not going to overdose because you're titrating to effect. In terms of administrative issues, most of these you don't have to deal with. Dr. Teresa Smith and I are the medical directors of the program, and we're going to be dealing with most of this stuff, and Logan will be dealing with some of it. The things that you need to know is the patients who we train are going to get the blue card. It's in the kit. That's the completion certificate. There's an enrollment form, and then they get the kit. Just check the expiration date on naloxone before they get the kit, although we shouldn't have any expire because pharmacy is controlling our supply, and so they should be taking care of that. Just to remind the person that if they use it, to report it and to get refill. This is what's in the kit. There's 2 of these nasal sprays, there's the gloves, and there is the rescue breather, and a card for some information. This card, so the NCAP program is basically limits the cost in New York State for patients with insurance. The state will cover the cost that their pharmacy, that their insurance plan doesn't cover, except for $40. So somebody will be responsible for $40. The state will pick up the rest if their insurance doesn't cover it. And there's no provision for people who have no insurance. We don't really have to worry about this because we're giving them the kit. They don't have to worry about insurance or paying for it or anything. There's a standing order. This is basically all of these are being distributed, being ordered by me, so you don't have to worry about that. And again, for documentation, most of this you don't have to worry about. You have to worry about the enrollment form and the card. Storage, again, we're going to be dealing with this, but an important thing, yes?
Are we going to document it in the T system that we gave it to them or not?
So you're going to order it in the T system. So we do have a policy and procedure for this that's passed P&T for the hospital, and that it's already established within the rules of the hospital for how we're going to be distributing it. And Dr. Chen from pharmacy is making sure that we have an orderable in T system, and when you order it, that's going to keep track of it. It's being kept through Pyxis, and so they're going to be distributed that way, and everything that's going to be recorded that way. Yes?
Do we have it at county then?
Not at county. For now, we're starting at downstate.
So they are in the Pyxis, it's not like hidden in the ramp or something, it's.
No, they're all going to be in Pyxis so that they're controlled and there's a record of what drugs are dispensed.
So, if they're not a patient, like someone comes in and they want it for their significant other, they have to register though, right? So we can order for them in the T system.
I think that is the case, yeah. So you can give it to somebody who's not a patient under New York State law. You just have to do the training. I guess you could document it under the patient. Like if there's a family member of a patient that's at risk, you definitely would want to give that person a kit. That's somebody that potentially could save them. I don't think we have a provision for somebody who's not registered because they're orderables in T system.
You might have a difficult time with the nurse actually getting it out of the Pyxis because they have to do it based on the other patient's name. And even though it's not a chargeable event, I think it'd be best to try to get them to register so that everyone involved would be comfortable.
Yeah, and it's also important because that's how we're logging them.
New York also, you can go online and there's a list of all pharmacies in New York State that have kits available as well.
Yeah, but then they're gonna have to pay for it.
Yes.
Here we can give them the kit for free, so I think it's preferable.
Encourage them to register so they can get
But
it.
if they register, they've got a weekly visit kit. It'd be $600.
We could back those out. I mean, if we're talking small numbers, it's like, like a few, I think, maybe unless the word gets out and understand you can hit essential.
Yeah.
But we could, from the administrative perspective, if you get a list, each week, I think we can talk to people and back those out, on the back end. I don't think it's just a big number.
Yeah.
I'm sorry, Robert. Do you have an idea of what we're looking at?
I don't know the number. I mean, if we include all of our sickle cell patients that are on high-dose opioids at home, that could be a lot.
Yeah.
The number of people we see with heroin or fentanyl overdoses at downstate is pretty low. So I'm not sure what the numbers are going to be yet. We're going to have to see how many kits wind up getting distributed before we can really track that. I know that I think we're not the only source of these kits in the community. The Star Clinic is also ramping up their program and they're going to be starting to distribute them also. So we won't be the only ones even within the hospital that's a source of the kits, but because we may be the only encounter that some of these patients have, especially if it's an overdose from recreational use as opposed to somebody with chronic pain, they may not go to any of the clinics, and so it's important that we have the ability to give those kits out.
You were saying, maybe I missed this, but you said that when people use them, they should report that they use them so they can get another one. Who are they reporting it to?
I'm not sure. There's a form in the kit, and I think it's to New York State, that it's basically under the Department of Health through the
And
Naloxone
they'll send them a new
program.
one?
No, they're still going to have to come back to one of the distribution centers to get a new one.
Oh, it's just encouraged to let them know that it's
Yeah.
been used. I see.
Is it possible to distribute the kits to each one of the residents, the attendings to have, or as carry around and
I think if you get registered, absolutely. So that's one way we can do it. I don't think we have a provision to just distribute kits without some kind of record of training. Everyone here, I'm going to need the attendance from today's session because everyone here is going to be logged as having been trained. But so you certainly could have a kit, and I think it's a great idea. Especially keep it in your car if you pass someone on the street. You might be able to save their life. I think it would be a good idea. But again, I think we don't really have a mechanism to distribute without the patient being registered right now.
Don't you think the majority of people that come to the ER looking for these kits are going to be significant others of?
Yeah, I think that's going to be.
And I would think that the person who's the user is not going to accompany them. They're just worried about their loved one, and so they're going to come. So we have to register those people, even though they are not the person who's the user.
Yeah, I mean, I think that's the only way it can work right now, with the mechanism that we've set up to distribute.
But even if they come to the person because there was an overdose situation and the patient is now here because of some sort of unintentional overdose, you really should be training not just the patient, but the family members with them, because it's going to be the patient that overdoses, it's going to be family members that are going to be giving naloxone.
Yeah.
It should be a group discussion so that everybody who's accompanying the patient is aware of how to use it.
But even if there's no family member with the patient,
And they're coming
It's important to train the patient because it may not be them that overdoses, it could be one of their buddies. And so, people tend to use with other people that use in general. So, having them out in the community is beneficial.
Are there any plans to have like any use of media in training as well, like maybe a YouTube thing that people can put a link on a discharge instructions?
I don't think we have that yet. I know Harm Reduction Coalition, where I did the training, is developing an electronic program to replace the 3-hour thing that I went to. But right now, I don't think that there's a mechanism to count that as training. Yeah.
We're gonna do it as a group, and I agree with Teresa, you have to, and you, but you have to have a group there. It's not gonna be a patient, it's gonna be the family or the friend. And, where at UHB do you think is the best place to do that? It's gonna be hard if they're out in the hall or the cubicle. Where do you think is the best to do that and to demonstrate stuff?
I mean, honestly, I think realistically, it's probably going to be at the bedside. I don't know. Maybe in Margaret's office would be another option.
I was thinking of mine,
Yeah,
and
maybe.
that, and you let the nurses know that that's what we'll do it. We'll need to have the training, it's gonna take a while.
Yeah.
Is there a training checklist somewhere for?
Yeah. So I sent it out this morning to everyone, to the listserv, so you should be able to get it. That's kind of like the bullet point stuff you have to get through. And remember, it's only those first 3 elements that are critical. The risk factors and Good Samaritan law and stuff are not as critical.
In terms of the patients that we're targeting for this program, I mean, I guess, narcotic abusers are obvious, but the cancer patients on high-dose narcotics and then our sickle cell patient population, are there certain criteria that we should be looking for in terms of what patient is going to be a good candidate for this?
I think anyone who chronically uses opioids in large doses. So that's basically going to be abusers and chronic pain patients.
Okay.
And there's no set criteria though.
Okay.
Yes.
What's the duration of stability? Like how often do you have to come?
So they all have expirations on them, and the kits are actually stable for much longer than the expiration date. Whether the mechanics of the device are still effective, how long those remain is not as clear, but most pharmaceuticals are quite stable. And actually, looking at one of my colleagues at the Poison Center had done a study looking at atropine in a World War II nerve gas defense kit and found that it still had like 90% of its activity 70 years later. So these things are pretty stable. You're not going to lose that much of the dose over time, but the mechanics of the device are less clear. But they all have expiration dates on them. It should be clear that they should turn in the kit and get a new one if it's expired. But if they encounter an overdose patient and they only have an expired kit, they should still use the expired kit. I just have a couple more.
What dose of naloxone is administered?
So they're 2 mgs.
Oh.
It's a pretty big dose. And I think they're concerned about fentanyl and fentanyl derivatives, and they want to make sure that people in the community aren't underdosed because they don't have the airway and rescue breathing skills that we do in the hospital. So just a couple more things. For storage for this, you don't really have to worry about this in terms of how we're storing our naloxone, but we should tell patients don't leave it in a place that's going to get really hot for too long. Occasional heating or freezing is probably okay. This is looking at effective temperature naloxone in naloxone that was stored at high temperatures, and even after like a month of being improperly stored, most of the activity was there. You can actually use it in minors, but in terms like if there's a child with a parent that comes in overdosed, then you potentially could train a teenager or something to potentially save their parent. They need to be deemed mature intellectually and emotionally, so you have to document that in the training. So we can skip that. Whether 2 doses is enough is not 100% clear, but it seems like in most cases 4 mg of naloxone is going to reverse most overdoses. and I think I spoke about this stuff already. Just a little bit of the data behind the efficacy here. In Massachusetts, which is one of the areas that this was really piloted, they started distributing naloxone in the community, and overdose rates lowered by 24 to 46%. So pretty significant. And there's always a concern if patients feel like they have the safety net of the Narcan kit, are they going to be more aggressive and use higher doses of drugs or use more? And that doesn't seem to be true based on the available data. And then there's a question, is it an issue if EMS isn't called? And a study in Copenhagen looked at this. Over 2,000 patients were identified and discharged by EMS over 10 years after being reversed with Narcan. In the next 2 days, 14 of those 2,000 patients died, and only 3 of them were from potential rebound overdose, so a tenth of a percent, so pretty low rate. But we still want the patients to, the people who use the kits to stay with the patient for 3 hours. That's probably true, absolutely. In New York State, the patient who's non-medical who gives naloxone in the overdose setting is protected. They don't have to worry about liability. And again, encourage the patients that this is a safe and effective medication and they're not going to hurt someone by giving it. All right, and so this is just an acknowledgement of New York State Department of Health, New York City Department of Health, Opioid Overdose, Naloxone Network, and also Harm Reduction Coalition. Bill Matthews is a really great guy, and if any of you are interested in taking the full course, I highly recommend it. It was actually really good. I went into it quite skeptical that I was going to learn anything, but I actually enjoyed it a lot. Any other questions? Yes?
If we were to get prescriptions for this to ourselves so we can carry, do you know what the going rate is now?
Well, if you have insurance, so if with the CAP program, you won't have to pay more than $40 as a copay.
Okay.
You said when are we going to try to start to go live?
Hopefully, I'm going to be doing this same presentation, maybe a slightly more abbreviated version at the faculty meeting in 2 weeks. And so after that, hopefully within a